Hi guys, the topic for today is the orbital decompression. Starting with the introduction. The finite capacity of the bony orbit means that increase in the tissue volume usually result in the anterior displacement or orbital content. So there is a finite capacity of this bony orbit, and any increase in the tissue volume may be either due to the hypertrophy of the extraocular muscles or the fat will eventually result in the anterior displacement of the orbital contents. So where we can see them, the thyroid eye disease is a commonest example. The hypertrophy of the extraocular muscles and the fat produces cosmetic embellishment, the corneal exposure, the ulceration, the prolapse of the globe, the diplopia, and the compression of the optic nerve leading to the visual loss. So what is the goal basically of the surgical decompression? The goals of the surgical decompression of the orbit is basically to expand the bony orbital confines to make the room for the increased volume of the orbital contents. Surgical decompression was first described by the Dollinger, who advocated the removal of the lateral orbital wall for the decompression into the temporal fossa, Crowley's procedure. Then the Nafzigers reported the via transcranial approach. So here we can see this is the superior approach, the Nafziger's approach, the Crowley's approach, the Hirsch approach inferior. This is the maxillary sinus. So this is the infraorbital wall. So this is removed so that the fat can be decompressed. Orbital contents can be decompressed inferiorly. This is the inferior approach. This is the lateral approach, Crowley's approach, Nafziger's superior approach. This is the lateral approach, and this is the lateral and inferior approach combined, or GAURAV approach. So this is a diagram of the coronal section through the skull and the paranasal sinuses showing the portions of the orbit removed for the various method of the orbital decompression. Now the decompression into the paranasal sinuses was first advocated by the Sewell, who described the decompression into the ethmoid air cells. These are the ethmoid air cells. So Sewell advocated this decompression into the paranasal sinuses. Hirsch, who later reported the inferior decompression into the maxillary sinus by removal of the orbital floor. So this orbital floor is removed and decompression is into the maxillary sinus. Walsh and the Augura combined. So this is the Augura approach. Combined the inferior and the medial approaches into a single transantral decompression of the two orbital walls. These are the two orbital walls, the lateral, the medial and the inferior. So using the Corwell loop approach. So let us talk about the surgical anatomy. The medial wall, basically this is the medial wall, the lateral wall, the superior and the inferior wall. So the medial wall basically comprises of the frontal process of the maxilla, the lacrimal bone, the lamina propria of the ethmoid and the body of the sphenoid, whereas the inferior wall, it comprises of the orbital plate of the maxilla, the zygomatic orbital plate anterolaterally, the orbital process of the palatine bone. Now comes the lateral wall. It composes of the greater wing of sphenoid. This is the greater wing of sphenoid, the orbital surface of the zygoma, the zygomatic process of the frontal bone, the superior orbital fissure. This is your superior orbital fissure. So this is your lateral wall. Now comes the superior wall. So superior wall consists of the orbital plate of the frontal and the lesser wing of sphenoid. Here you can see this is the lesser wing of sphenoid. This forms the superior wall and the superior orbital foramen. This is your superior orbital foramen. This comprises your superior wall. Now, what are the indication? As previously said, a thyroid eye disease. So decompression of the thyroid, ophthalmopathy, the sphenoid wing meningiomas, the compressive optic neuropathy, cosmesis, large myopic globes. So what is the preoperative assessment? The physical examination confirms the upper and the lower eyelid retraction, proptosis, and other physical signs of hypothyroidism. Complete ophthalmologic examination, complete head and neck examination, including thyroid status. The ultrasound can demonstrate thickening of all the extraocular muscles. So need to be done, and the CT scans of the orbit are essential, should include the paranasal sinus and rule out any sinus disease, and of course the thyroid profile need to be done. So here you can see this is the axial and this is the coronal CT scan of the thyroid eye disease, showing the classical Coca-Cola. You can see this, the classical Coca-Cola bottle sign of the auto decompression and the compression of the orbital apex due to the enlarged extraocular muscles. These are enlarged extraocular muscles and the orbital apex is compressed. Now the surgical techniques already explained. The superior orbital decompression, medial, inferior, lateral orbital decompression, endoscopic orbital decompression, and the orbital fat removal. Now let's talk about the superior orbital decompression. Well, the unroofing of the entire of the superior orbital wall by a craniotomy exposes the orbit by a frontal craniotomy. After the optic nerve has been identified, the bony roof of the orbit is removed from anterior to the optic foramen to the anterior superior orbital rim. Now the superior periosteum is then incised in an S-shaped fashion, and the orbital fat is allowed to herniate into the cranial vault. A titanium mesh and the pericranial flap are used to close the defect. This approach is used in very severe cases due to the associated morbidity. So the complication obviously are the meningitis, the cerebrospinal fluid leak, and the pulsatile proptosis. Here you can see the titanium mesh is being placed, the sphenoorbital meningioma resection and a reconstruction. Pre-molded titanium mesh is used. Now let's talk about the medial orbital decompression. In medial orbital decompression, basically the external ethmoidectomy incision are or through a coronal forehead approach. The ethmoidectomy approach displaces a medial canthus tendon and elevates the lacrimal sac out of the fossa. So here you can see the ethmoidectomy approach displaces a medial canthal tendon and elevates the lacrimal sac out of the fossa. Anterior and posterior ethmoidal arteries are identified and clipped. So here is a standard external ethmoidal incision for the medial orbital decompression. After decompression, the orbital fat herniates into the sinus defect. A complete ethmoidectomy is performed, removing all the mucosa bearing septa. The posterior ethmoid cells are removed back to the posterior ethmoid plate, and a medial orbital periosteum is incised longitudinally. Now let's talk about the inferior orbital decompression. Basically, it is done through the subciliary and transconjunctival or the caudal loop incision or the combined approach. So what we do here, our skin muscle flap is elevated in the lower eyelid. A skin muscle flap is elevated in the lower eyelid and the orbital rim is visualized. The periosteum is incised and elevated from the orbital floor for approximately 4 centimeters. Now here you can see the caudal loop incision is made sublabally and a wide enterostomy is formed. Then the course of the infraorbital nerve is visualized and the bone medial and lateral to the nerve are removed. So we will identify the infraorbital nerve and the bone medial and lateral to it is removed. The remainder of the floor is removed under direct visualization. 3 cm anterior posterior range for bone removal is safe, and medial removed by the lacrimal fossa. 2 lacrimal fossa and laterally removed to the zygoma. So here you can see this is completely removed. So So the periorbita is incised longitudinally, number of incisions determined intraoperatively, and 4 to 6 usually adequate. The fat herniates into the defects on either side of the nerve, and the middle medial ostium enlarged to provide ventilation and drainage of the sinuses. Now let's talk about the lateral orbital decompression. The corneal direct rim incision. So this is the lateral side of the eye. So coronal direct rim incision or extended lateral canthotomy. Periosteum over the lateral orbital rim is exposed and incised widely. It is elevated from the orbital side of the infratemporal fossa for approximately 3 to 3.5 cm posteriorly. Here you can see what is this. This is the right lateral orbitotomy through a curvilinear incision, exposing and removing the lateral orbital rim. This is the lateral orbital rim. So here what is this? The herniation of the orbital fat through the defect creates into the temporal fossa. Lateral orbital rim can be cut and mobilized, leaving its attachment to the periosteum to assist with closure. Much of the lateral orbital wall can be removed about 2.5 cm to 3.5 cm. Periorbita is incised and fat teased out into newly created space. Now let's talk about the endoscopic orbital decompression. So what happens here? We can see these are the ethmoid air cells, the maxillary sinus. This is the periorbita. This is the orbital fat, and this is the infraorbital nerve. And this is your globe. So what we see, the ethmoid air cells are removed here. So the medial and the medio-inferior floor, the medial and the medio-inferior floors of the orbit can be removed through a transnasal approach. So the uncinate process is taken down and large antrostomy is created, opening superiorly to the level of the orbital floor. Superior to the large antrostomy is done superiorly to the level of the orbital floor and inferiorly to the floor of the inferior turbinate. Middle turbinate is resected, so the middle turbinate is removed. Ethmoidectomy is performed and the anterior and posterior ethmoid arteries are identified. Medial orbital wall is exposed from the fovea ethmoidalis to the anterior face of the sphenoid sinus. Trocar inserted through the canine fossa can allow the visualization through the puncture while working through the nose. Then the infraorbital nerve is identified as a mucosa elevated from the roof of the maxillary sinus. The lamina praeparatia is fractured and removed to the level of the ethmoid arteries. So here is the lamina praeparatia which is fractured and removed to the level of the ethmoid arteries. Bone removal is carried superiorly within 2 mm of the fovea ethmoidalis, posteriorly to the face of the sphenoid and laterally to the nerve. A buttress of bone is preserved anteriorly at the junction of the inferior and the medial orbital wall to avoid the excessive inferior displacement of the globe. Orbital periosteum is incised superiorly in a posterior to anterior direction with a sickle knife, taking care of avoid excessive penetration with the knife. Orbital fat protrudes into the ethmoid cavity. Silastic splint is placed to avoid the postoperative adhesions and packing is not used. Endoscopic approach allows a mean reduction of proptosis of 3 mm. Now this is the diagrammatic representation. Now here you can see this is the lamina praeparatia, this is the maxillary line, this is the enlarged maxillary ostium, this is the sphenoid ostium, this is the septum, and this is the ethmoid roof. So a view of the right nasal cavity after a wide maxillary antrostomy and the sphenoethmoidectomy are performed. The skeletonized lamina praeparatia is fractured with a spoon curette. Now here you can see a black slate. Forceps is used to remove the fragment of the lamina praeparatia. A fierce elevator may be used to separate the thin orbital bone from the underlying periorbita. Now here you can see the spoon of the mastoid curette. A spoon or a mastoid curette is used to down fracture the medial portion of the orbital floor. The floor is removed medial to the infraorbital canal. Now here you can see this is the periorbita, this is the area of the orbital sling, and this is the orbital fat protruding. So after the bony decompression, a sickle knife is used to incise the periorbita. In patients without the optic neuropathy, a sling of fascia may be preserved. So this is a sling of fascia which is preserved overlying the medial rectus muscle, because behind this is the medial rectus muscle, to minimize the post-operative diplopia. So this area will be preserved. This is a sling, you can see orbital sling which is preserved, and this is the herniating fat. So in this diagram, this orbital sling is removed and this we are keeping it. So after the decompression, orbital fat protrudes into the ethmoid and the maxillary spaces. In A diagram, we can see with the orbital sling technique, a strip of periorbita remains to support the medial rectus muscles and reduce the incidence of the post-operative diplopia. Whereas in this diagram, you can see the maximal decompression can be obtained for patient with the optic neuropathy by removal of the entire periorbita, including the sling. The sling is removed. These are basically done in patients with the optic neuropathy. Now here you can see an enlarged bone curette is used to enter the bone of the lamina praepacia. The fractured bone is elevated away with the Freier's elevator and removed. In this diagram you can see this is the medial rectus muscle. The exposed orbital periosteum is incised in the posterior to inferior or to anterior direction using a sickle knife. The incision can be made above and below the medial rectus muscle, above and below the medial rectus muscle, to prevent direct entry to the muscle. Now here you can see the incised periorbita, fascia and the orbital fat allows for the herniation of the orbital content into the ethmoidal sinus cavity. Now the orbital fat decompression. The orbital fat decompression or removal can be used either in isolation or in conjunction with the other bony decompression procedures. It is first described by the Trokel in 1993. This procedure involves opening the periosteum using an extended transconjunctival approach. Under the direct visualization using the bipolar cautery, dissolve the fat between and around the extraocular muscles. 2 to 3 mm decrease in the proptosis can be expected. A significant reduction in the diplopia and an improvement in the visual acuity. Now when we talk about the complications, these are the diplopia, the optic neuropathy, the paresthesia, the unsatisfactory result, corneal abrasion, excessive retraction on the globe, retrobulbar hematoma, injury to the infraorbital nerve, the ectropion, the retinal hemorrhages, and the orbital cellulitis, epiphora, and the cosmetic problems. Thank you.